Hello friends, today we'll be discussing on a topic of histophysiology, pathology of root apex. Myself, Dr. Kripa. Hope I am audible to all. I am senior lecturer in the Department of Conservative and History of Endodontics, Royal Dental College, Malaysia. So as an introduction, Periapex is an area which is present beyond the tooth apex. Injury to any calcified structures of teeth by any noxious stimulant will cause certain changes in both pulp and periradicular tissue. The periodontium is actually something very large than a pulp with a lot of complex tissue. So if it is a periopical lesion, you can assume a great size. The relationship between pulp and periopical pathosis is very close. Pulpal involvement is usually a forerunner of any periopical pathosis. Historically, when X-rays first began to reveal dark areas of apices of teeth, they were called as bags of infection, and then theory of focal infection came into being. This was published in a book by V.D. Miller, and it was later Dental Cosmos who first used the term focal infection. And Miller felt that it is not necessary to remove a teeth as a focus of infection and suggested that you can go for root fillings. Now, the theory of focal infection is first described by Rosenau as a localized or generalized infection caused by a bacteria which travels through a bloodstream from a distant focus of infection. Later, in the 1930s, Dr. Weston Price presented research suggesting that bacteria which was trapped in dental tubules during root canal treatment could cause almost any type of degenerative system problems. There was the importance of focal infection. So now the histophysiology. Apical periodontium of a tooth is concept with cementum, periodontal ligament, and alveolar bone. All are interdependent. Nothing is independent. Cementum, in the coronal 2/3 of root, the cementum will be thin and lamellated, and due to the more functional stress, cementum towards the apical end will be wider, and when it is more functional, it will be more cellular and more irregularly lamellated. The cementum has the basic function to attach principal fibers of PDL to the tooth. The other function that will affect endodontic diagnosis and treatment include the continuous deposition of cellular cementum around apical third of root, which compensates for any attrition, called as passive erosion. This deposition results in increased tooth length and lot of constricted apical canals. Excessive constriction of apical canal can affect the blood flow to the pulp and induce certain retrogressive or age changes. Then the terminal area of intercanal preparation is CDJ. That is something which is very important as far as cementum is concerned. Our root canal preparation should end at what is called CDJ, which may or may not coincide with your minor constriction. This is 1 mm from apical foramen. It is also referred to as the histologic foramen, being the junction of pulpal connective tissue with the interstitial tissue of PDA. Another importance of cementum is it repairs root resorption, which is either pathologic due to granuloma or physiologic due to some tooth migration. As a result of the resorption followed by cementum replacement in migrating teeth, the apical foramen will undergo a lot of changes to a more lateral position. The loss of cementum from the cervical position of tooth may render the tooth hypersensitive to thermal changes because of the exposed dentinal tubules. This may complicate identification of and approximating tooth, which is requiring an endodontic treatment. So again, it was Hansen who shows evidence to support the cementogenic theory of root repair. A continuous deposition of cementum can occur at the fractured ends of two segments of a horizontal root fracture, joining them and affecting root repair. Peter C. Coffin has shown that cementum contributes to the hard tissue barrier at the root end as a result of apexification procedure. Periodontal ligament has two different types of tissues, each with its function. One is the suspensory ligament, the other is periosteum. The space between principal fibers are occupied by loose connective tissue. This loose connective tissue has a lot of functions: formative, nutritive, nervous, and defense. And this histologic makeup provides several endodontic considerations. Nervous function. The pressure receptors terminate in and around the bundles of principal fibers. Thus, the ligament portion provides a proprioception function. The loose connective tissue also has certain nerve endings for pain reception. Identifying a tooth with acute pulpalgia is difficult because only pain receptors are evident in pulp. Localization of pain is facilitated by when there is extension of this response to the periapex, which activates both pain and proprioceptive responses. Pulpoperiodontal junction. Pulpal tissue response to a written does not end at this demarcation point called apical front. Connective tissue of pulp forms a continuum with the interstitial loose connective tissue PDL at this junction, which can again continue to the marrow space. When inflamed vital pulp may be accompanied with tenderness to percussion with or without any radiographic evidence of changes in the periapex. This formation, remnants of the Hertwig's epithelial root sheath, which remains in this loose connective tissue called rest of molasses, are dormant until activated by some kind of inflammatory growth factors, resulting in formation of a cyst. Alveolar bone. Alveolar process consists of alveolar bone proper and supporting bone. Alveolar bone proper is a thin layer of compact bone which lines your socket. It appears as a radiopaque line, hence called as lamina dura. Alveolar bone proper is made of lamellated bone, lamella being arranged parallel to the surface of PDL space and in small Haversian system. Seiker named the same as bundle bone to describe alveolar bone which contains attached in the principal fiber bundle called Sharpie's fibers. Cribriform plate is an alveolar bone proper with sieve-like surface. These are perforations for the passage of interalveolar nerves vessels as well as coalescence of connective tissue of PDL with that of marrow space. During stress period, osteoclasts are found to increase in the space. A persistent periapical inflammation will result in resorption of your lamina dura. Radiographic detection of loss in continuity of compact bone is an effective diagnostic aid for an endodontic infection. Absence of break in lamina dura necessarily does not rule out any early infection because for a radiographic change to be evident, there should be 30 to 50% loss of minerals of the bone. Supporting bone that surrounds and gives support to alveolar bone proper of tooth socket consists of cortical plate of compact bone with intervening spongiotrabecular bone. So Bender and Seltzer demonstrated that if a lesion does not encroach on junction between cortical bone and cancellous bone, it is not usually visible on radiograph. A lesion around mesial root of lower first molar is more visible on radiograph than a distal root because they are more closer to the cortical plate. Angulation of X-rays will determine the accuracy of interpretation of healing or a clinical breakdown. Trabeculation or trabecular cancellous bone has a septal or labyrinthine arrangement of lamellae with its marrow forming a continuum with interstitial loose connective tissue of PDL. Since specific receptors for pain are not present in trabecular space, healing associated with extension of inflammatory response into the marrow space is fullness or continuing pressure. Pain receptors present in the blood vessel sheath or pressure on the nerves passing through the area will create some amount of referred sensation. Pain receptors are numerous in periosteum that covers cortical plates and in specialized periosteum of PDL, which is the interstitial connective tissue. Pressure in these areas produces pain of varying intensity. So this shows your apical foramen, the root apex, in a cross section. So now WHO has classified apical periodontitis as subcategories: acute apical periodontitis, chronic apical periodontitis, periapical abscess with sinus, and that is subdivided as based on where the sinus is communicating. Periapical abscess with sinus to maxillary antrum, periapical abscess with sinus to nasal cavity, periapical abscess to sinus into oral cavity, periapical abscess with sinus to skin. Then next category is periapical abscess without a sinus. Then there is radicular cyst. Radicular cyst is again subdivided as apical and lateral cyst, residual cyst, and inflammatory paradental cyst. But this does not take into account the structural aspect. What they take into account is histopathology. And this system is based on 4 factors: how inflammatory cells are distributed, whether epithelial cells are there or not, whether it is transformed to a cyst, and the relationship of cyst cavity to the root canal. Histopathologically, lesions of apical periodontitis are acute, chronic, or cystic. Acute can be primary, which is short-lived initial phase, starting in a healthy phase and response to irritant. Secondary is an exacerbation, like a phoenix abscess. Then there is established or chronic lesions, chronic apical periodontitis, a long-standing condition with chronic inflammatory cells. Then you have cyst, a true cyst, and a focal cyst. True cyst does not have any communication to the root canal. They are a distinct cavity enclosed within the epithelium. Pocket cyst will have a communication with the root canal space. So this is the classification. You can see how an acute can turn chronic and a chronic can turn a cystic. Another classification by Wien as painful pulpoperiapical pathosis. In that you have incipient acute case, advanced acute apical periodontitis, again subclassified as acute periapical abscess, acute exacerbation of a existing chronic condition, subacute periapical abscess. Non-painful pulpoperiapical pathosis, subdivided as incipient, chronic apical periodontitis, advanced chronic apical periodontitis or osteosclerosis. Advanced case is again subdivided as periapical granuloma, periapical cyst or chronic periapical abscess. Next is Grossman's classification. That is something that you people have to know. Grossman has classified this in a rather easy way. According to Grossman, acute periodicular disease is subdivided as acute alveolar abscess and acute apical periodontitis, which can either be in a vital tooth or a non-vital tooth. Chronic periodicular disease, subdivided as chronic alveolar abscess, periapical granuloma, cyst. Then there is condensing osteitis, external root resorption, diseases of periradicular tissue of non-endodontic origin. So now, according to the American Association of Endodontics, pulpal diagnosis for a normal pulp is actually responsive. Many students still confuse here. Pulp will definitely respond. We have to assess what is the pain threshold of that particular patient. So when you do, that's why when you do a vitality, we suggest you do it on a controlled teeth first. This is to understand how the patient normally has responded. Then only we can compare it with an affected tooth. Is that clear? So now for a reversible pulpitis, there will be a sharp pain, but it is very momentary. Pulpal test will respond. But as soon as you remove the stimulus, the pain will also disappear. Then you have irreversible pulpitis. That too can be symptomatic. Then it is the sharp pain, which may be deep-seated, dull, gnawing pain, spontaneous pain, or referred pain. And the pulpal test will respond, but the pain will continue to be lingering for a long time. Asymptomatic irreversible pulpitis, patient will not give such a history of pain presently, but he gives a past history of pain. And the pulpal responses is just like what we have seen. Pulpal necrosis means patient doesn't have any pain symptoms, and the pulpal response is also nil. Previously treated also the same. Then we have the periodicular disease diagnosed. Normal apical tissue, you don't have any apical changes. The apical tests are normal. Symptomatic apical periodontitis, the patient will have pain. Radiographically, usually not much changes are seen, just a small amount of PDL widening. And the response to percussion will be painful. Asymptomatic apical periodontitis, patient will not have any pain, but you can see a definite apical radiolucence. And the periapical test will also be negative. Acute apical abscess, a patient will have a definite swelling with very high pain, pressure pain. Here it can be with or without any radiographic changes, periapical. Response also the same way. Sometimes they might respond, sometimes the pulp will already be necrotic. Chronic apical abscess, the presence of sinus tract will help you understand that it is a chronic abscess. Usually there is a definitive periapical radiolucency and the tooth will not respond to percussion, as there is a leeway for the infection to come out, which is the sinus tract. Condensing osteitis, the patient will be with or without pain. You can see a definite radioopacity associated with the root apex. The response to percussion will also be sometimes positive, at times negative. Now, the sequelae of pulpal pathosis is clearly shown in this type. Again, this is from Grossman. Very important table. When there is an irritation, the pulp gets inflamed. There is hyperalgesia because of reactions in the pulp, which can turn into a non-painful pulpitis or a painful pulpitis. Painful will be symptomatic. Non-painful means it is chronic, and that can change into an apical periodontitis or an internal resorption. Painful pulpitis, if untreated, can change into non-painful and then to a chronic situation. Sometimes straightly it can go to necrosis and then to apical periodontitis. This is how the sequelae is. Next is the pathogens. Now, apical periodontitis, the development of this is usually following a total pulpal necrosis. So you have certain theories to explain this. The first is pulpal strangulation theory, describing the generalized increase in pulpal interstitial pressure within an uncompromised pulpal space during pulp inflammation, causing collapse of venules and cessation of blood flow. So in studies have concluded that Uncontaminated necrotic pulp that are intentionally devitalized or accidentally traumatized are incapable of inducing periopical inflammation unless they are infected. However, if vital pulp becomes infected due to some caries or other ways, periopical inflammation can develop even when inflamed with but vital tissue is still present in the apical part of root canal. The biologic basis for the observation here is that there is many inflammatory mediators being released and toxins which can occur even prior to total pulpal necrosis. So that's why even prior to total necrosis of pulp, periopical changes or destruction can start. So now to define an acute apical or a symptomatic apical periodontitis, an acute inflammation of periodontium of endodontic origin with the presence of PMNs in the lesion. Etiology is usually irritants diffusing from an inflamed or necrotic pulp, ingress of irritants, any medicaments being extruded out, debris pushed into periradicular tissue, or some physical irritation of periapex and trauma. Clinically, there is pain on percussion, slight tenderness, and when you give a firm pressure against the mucosa of the root, then there is a positive response, may or may not respond to vitality. The release of chemical mediators and their action on nerve fibers and periradicular tissue causes pain in this situation. And pain is induced by sensitization and activation of nociceptive sensory nerve fibers by the inflammatory mediators. Histopathology is an acute condition. You can see the acute inflammatory changes here with lot of neutrophils. The integrity of heart tissue has been disturbed. Periopical changes are becoming detectable on the radiograph. When infection is involved, neutrophils will go on releasing lot of mediators, and that's what is creating the destruction. Initial rapid bone resorption can be prevented with the administration of indomethacin. Neutrophils die in great numbers at the inflammatory site and release enzymes from their suicide bag, causing destruction of the matrix there. Later stage of acute response, macrophages will start to appear and bone starts to resorb. All these are the actions of the various inflammatory mediators in the root apex. So acute early lesion may take any of the courses. Either it can heal spontaneously with the proper initial pulpectomy, or it may intensify and spread towards the bone if the destruction continues. It can open up to the exterior also, and that can get scarred or it can turn chronic. Next is a chronic apical periodontitis, which is a long-standing inflammation of periodontium of endodontic origin, with the presence of granulomatous tissue infiltrated with chronic inflammatory cells. Either it may be preceded by an acute apical periodontitis or by an apical abscess. So inadequate root canal treatment can also develop as a chronic lesion. Lesion develops and enlarges without any subjective signs and symptoms. Long-standing low-grade inflammatory reaction of periapical connective tissue can result in chronic condition. So clinically, patient doesn't have any pain nor a tenderness. Tooth is usually necrotic and so not responsive to vitality. Being a chronic situation, you see a lot of chronic inflammatory cells and bony resorption. And this is brought about by mediators. Radiographically, you can see a periradicular radiolucency, changes from thickening of PDL, resorption of lamina dura to a well-demarcated radiolucency. Chronic condition, if allowed to continue, can turn as a granuloma. Periopical granuloma is an advanced state of chronic apical periodontitis the growth of granulation tissue and ingress of chronic inflammatory cells with peripheral collagenous capsule. Reaction of periodicular tissue to noxious products of tissue necrosis or bacterial or antigens has been described by fish. Fish zones are very important. Established experimental foci of infection in the jaw of guinea pig was identified by drilling opening in the bone, packing it with wool fibers saturated with a broth of microorganisms. And 4 distinct zones were identified: zone of necrosis, zone of contamination, zone of irritation, zone of stimulation. Zone of necrosis or zone of infection, the presence of the necrotic pulp tissue in the root canal, the yellow one which is marked, resulting in the diffusion of toxic material beyond the pulpal space. This zone consists of pus with dead cells, destructive components released from the various phagocytes, PMNs surrounded by various other inflammatory cells. The green one is a zone of contamination. The toxicity of irritant is reduced by the fluid and cellular exudates. Principal exudative defense response is formed here, where the dilution of toxic elements are occurring. This reduction in toxicity will stimulate undifferentiated cells to osteoclast and resorption of periopical bone. Next is the zone of irritation, which functions as defense or healing. Mainly a proliferative response is seen here with lot of fibroblastic activity and capillary infiltrations. You can see the presence of defensive mechanism. The light blue is the zone of irritation. Next is zone of stimulation, the zone of encapsulation of fibrosis, a perfect healing zone with lot of fibroblasts forming collagen and osteoblasts forming bony deposition. Osteoblasts function best in this zone. Bone apposition and reversal lines are evident. So this is the fish zones. These are very important. You should know them in detail. Another concept was put forward by Cronfield, which is the mountain pass concept. Cronfield has pointed out that granuloma is not an environment in which bacteria lives, but the one in which they get destroyed. So as a few invaders enter the plain through the mountain pass are destroyed, mass attack of invaders results in a battle in the second zone, and then there is a complete elimination. So the objective, therefore, in a non-surgical root canal treatment in a teeth with periopical pathogens is to eliminate that irritation from the canal so that you can have a very good healing at the periopics. So radiographically, for a granuloma, you see a radiolucent area of variable size attached to the root apex, well circumscribed, demarcated by a bone with a thin radiopaque line or a sclerotic bone zone. Next is periopical cyst. Is an acute apical inflammatory cyst with a distinct pathological cavity enclosed with an epithelial lining, which is a true cyst. It doesn't have a communication with the root canal. So how the cyst formation occurs? In the first phase, the dormant cells will start to proliferate under the influence of growth factors. Second phase, epithelial line cavity is formed, and two theories have been explained. Nutritional deficient theory means the central cells, as the proliferation increases, are deprived of nutrition, undergoing necrosis and liquefaction, and microcavities are created. Abscess theory, that proliferating epithelium surrounds an abscess formed by tissue necrosis and lysis because of the inherent nature of epithelial cell to cover the exposed connective tissue surfaces. This goes on, and the apical pocket cyst, which has lumen opening to the necrotic root canal, can grow, eliminates osmotic pressure as a potential factor in development of radicular cyst. So the histopathology, you can see the cyst cavity with the presence of the chronic inflammatory